Bismillahir Rahmanir Rahim. Today, Assalamu alaikum wa rahmatullahi wa barakatuh. Today we're gonna speak about psoriasis, a very interesting topic that affecting many people. So we really need to understand how to deal with such disease. Simply speaking, psoriasis is a chronic skin condition. However, it's immune mediated dermal inflammation. So it has an immunomodulatory dermal inflammation consists of painful redundant papules that form plaques with distinct borders. Usually located in the elbows, scalp, knees, feet, and genitalia. So that's the general definition of psoriasis. However, to understand the pharmacology of those drugs that use in psoriasis, we really need to get back towards the pathophysiology of the psoriasis. As we said, it's an inflammatory disease. However, the main, most important characteristic in this field is, in the psoriasis, is that there is a rapid production of the cells, and as written here, new skin cells are produced about 8 times faster than the normal, let's say over several days instead of over a month. So usually the cells turnover in 28 days. However, in psoriasis you will have that turnover within 4 or 5 days, which is really interesting. So the problem here that the old, as written here, the old cells slough off is unchanged. This causes cells to build up on the skin surface, forming thick patches or plaques of red sores region converted with flaky, silvery white dead cells. Okay, the whole issue here that we really need to understand that there's a quick turnover. However, there's not a cleaning up of such cells, because usually we have dead cells within our skins. However, that dead cells happening, the turnover of those cells happening within 28 days. However, now in the disease that really mediated through inflammation and involvement of many cytokines, that will have those cytokines will increase the epidermal cells proliferation and the keratocyte proliferation, producing more cells, and those more cells will produce what's here, the plaques, and because it's not really slough off, if you like, and they will have this scales and plaques and so forth, so on. However, the interesting point here within this slide also to understand there's an inflammation, and that inflammation involve mediators. Now there's a different mediators rather than what we've done before in rheumatoid arthritis and also in gout. Here the different cells gonna be involved. It's gonna be T cells. However, here we have dendritic T cells that will produce, as usual, the TNF alpha will be there. However, we have a new mediators here. We have interleukin 23 and interleukin 17. So remember this: the mediators that really having the effect on the psoriasis pathophysiology, 3 things. It's the TNF alpha, the interleukin 17s and interleukin 23, and that's where we're gonna design an antibodies biologics where we treat such a disease. Okay, we will not really target the interleukin 1 as we've done in rheumatoid arthritis. We will not target the interleukin 6 or interleukin 10 as we've done in rheumatoid arthritis. Here we're gonna target the 17s and 23. Why is that? Because those are the cytokines that are driving the fasting of driving the inflammation and the quick proliferation of the cells, the keratocytes are and the epidermal cells, and that's the pathophysiology disease. Now, looking into the hypothesis, there's an old hypothesis. The first hypothesis here of psoriasis is a disorder of excessive growth and reproduction of skin. The problem is simply seen as a fault of epidermis and its keratinocytes. However, the second hypothesis, which is more close to the reality, is that's an immunomediated disorder. So there's an immune reaction in which the excessive reproduction of cells is a secondary factor produced by the immune cells, T cells, which normally help protect the body against infection, become active, migrate to the dermis, and they trigger the release of cytokines. Tumor necrosis factor, alpha antiparticular, which cause inflammation and rapid production of skin. It's not known what initiate the activation of T cells, and this is an important part. We don't know the initiator of that, but what we know that the immune-mediated models of psoriasis has been supported by observation that immunosuppressant medication can clear psoriasis. In reality, treatment options that we build, it's really built on the second part, second hypothesis, which is really has to do with the immunomodulation, immunodisease. So at first, the treatment options that we have, as usual, we'll talk about the treatment according to the severity of the disease. So if the patient have intermediate disease, a mild disease or intermediate or severe, we will use different type of drugs. Now, starting with psoriasis, if it's really mild, the first step here, it's a medication or medicated ointment or cream are applied to the skin. That's what we do if there's a mild. Now, if topical treatment fail to achieve desired goal, then the next step, this is interesting thing, we never done this before, would be to expose the skin to ultraviolet radiation. Here, ultraviolet radiation is very important when in the treatment of that type of mild to moderate psoriasis. This type of treatment, which is we call it a phototherapy. Now, if the phototherapy and the creams is not really working very well, now we need to go into the systemic or injectable diseases. Okay, so the third step involves the use of medication, which are taken internally by pill or injection. It's a systemic treatment. Okay, over the time, psoriasis can become resistant to the specific therapy, and the treatments may be periodically changed to prevent resistance developing and to reduce the changes of adverse reaction occurring treatment rotation. So, interestingly, it's a chronic disease. So don't think that the first treatment will continue with the patient all of his life. Sometimes you're having a resistance toward what you're really giving your patient. So you have to rotate sometimes between different type of treatments. However, the treatment, generally speaking, cascade, if you like, is clear on this slide. Now, if it's mild type, this is increasing toxicity, increasing effectiveness of the drug, and that gonna be increasing according to the let's say severity of the disease. So topical treatment here, if you like, we're gonna use it when the disease is not really it's within the mild or moderate level. However, if we go to the mild to moderate level, we may use this phototherapy. However, the severe type gonna use our guys, the biologics, targeting TNF alpha, targeting interleukin 17 now, and targeting interleukin 23, and we may use our immunomodulators, and this is one new one, cyclosporine. We've done methotrexate before, and we've done retinoids also before within the acne. So we will use those guys systemically when we have this sort of a severe resistant type of psoriasis. Now, what's interesting here, as we increase or we're turning from topical to photo to systemic, we're increasing the effectiveness, yes. However, we're increasing the toxicity. So this is an interesting part. That's why we don't start with the systemic unless we really need to. We really need to for it. So keep the biologics because they're having side effects. Keeping the cyclosporine, the methotrexate, the retinoids, and even keeping the phototherapy, the BUVA and UVB. Keep them until we need them. Usually we start with a topical treatment, and the topical treatment coming in four things. The first one is the magical corticosteroids. As usual, we use corticosteroid in many places. Here in psoriasis, we're gonna use it topically. And we're gonna use calcibitrol, which is the calcibitrol is like a derivative of vitamin D. Actually, we also use pericalcibitrol and bitriol, which is different derivatives from vitamin D. So all of them are derivatives of vitamin D, and we'll talk about them in a moment. We use another drug called anthraline and coal tar, all of them, what's really common between all those guys are they having an effect on the immune cells. So they gonna inhibit the T cells, especially the dendritic cells that are producing that type of inflammation. So that's what the common thing about them. So let's talk about the drugs. First of all, we use the topical CS meaning corticosteroids. As usual, corticosteroids are known to have an anti-inflammatory and immunosuppressive activity. Quick onset than coal tar and diethranol, which is the antral. Diethranol is the anthraline. It's like anthraline that we talked about in a moment. However, tachyphylaxis can occur, meaning the patient is responding toward the treatment. However, there is a resistant toward during the treatment, and we call this tachyphylaxis, which is let's say even tachyphylaxis, it's like tolerance. However, the patient will having an attacks during after that we treating the patient, so he will respond beginning, then he will not respond, and the disease will flare in case of tachyphylaxis. High potent agent used in severe cases, thick plaques. Now we will not talk about corticosteroids in terms of strong and weak and so forth so on, because we will do that in summer, as we said in rheumatoid arthritis. We will do it in endocrine. However, we usually use a mild type, because the mild type have a less side effects, if you like, for the disease, for the patient, while the strong guys or the most potent guys will have more side effects to the patient. So we really, it depends how severe is the plaques. The thickness of the plaques will determine the strength of the corticosteroid that we use. We usually take it either locally, and adverse effect may happening locally or maybe systemic. Now, usually systemic will not happening except in if you're using too much of steroids, applying too much of steroids over the body of the patient. So usually systemic side effects of corticosteroid will not happen. However, if you apply, let's say more than 30% of the body of the patient, you apply a topical cream on it of these corticosteroid, there's a systemic absorption for such disease, for such drugs, and may produce side effects. Interestingly, you don't stop those drugs. Don't stop those drugs abruptly. Don't do it. Don't stop it suddenly, because you get rebound psoriasis with the patient. So if you're gonna don't stop the drugs, either you're tapering down the drugs, or you're taking you make a tapering, or you're changing the patient to other type of drugs, because the psoriasis will rebound. So we're having something called rebound psoriasis if you stop the topical corticosteroid abruptly. So remember this. What you're gonna remember on topical corticosteroids, there is a side effect systemically if you use it too much. However, usually there's a local side effect of corticosteroid. And what's the local side effects of corticosteroid? Irritation. Although they're not, most of the patient will not be irritated, because we usually treat the dermatitis, which is an irritant type of disease, of skin diseases, with corticosteroid. However, we are really worry about using especially the potent type, because they're gonna affect the normal skin and may produce an atrophy to the skin. So that's remember this, atrophy meaning the shrinkage of the skin and so forth so on. Remember this, corticosteroid locally, topically, may produce atrophy to the skin atrophy. This is a characteristic side effects of corticosteroids. Now, what else we have? We have another drug called calcitriol, okay, which is a derivative of vitamin D. It's like the calcitriol that we talked about in the beginning. It's a derivative of vitamin D, act by slowing down the growth of the skin cells, usually topically, cream solutions in the treatment of psoriasis, safe for long-term application. This drug is really safe. There is no real systemic side effects from calcitriol, or calcitriol, whatever you call them. At the end of the day, they are vitamin D derivatives, and you will be really asking why such a drug gonna be used in treatment of treatment of a disease like psoriasis. What's really has been shown that calcibitriol and calcibitriol can inhibit the T cells proliferation and inducing apoptosis within these T cells. They have an, let's say, a significant studies has shown that there's a significant reduction, and that reduction in the gene expression of the cytokines like interleukin 8 and that activate the T cells usually. So if you've been asked why we use vitamin A, vitamin D derivatives, because they have an immunosuppressant activity. How do you do that? They may affect in the gene expression, generally speaking, and that gene expression may have an effect in interleukin 8, and interleukin 8 is a real good driver for the T cells, generally speaking. Before we turn to coal tar ointment, you have to understand that the combination now, what the guideline is, the guideline for the treatment of psoriasis coming in, or the medical people agreed on this idea. That's the most useful combination or treatment for the mild psoriasis is to combine two guys, to combine corticosteroid with with the vitamin D derivatives, and very effective, very nice in a work, little side effects. You don't have to use too much of corticosteroid to suppress psoriasis. You don't have to use the potent type even, because there's some sort of synergism, if you like, between the vitamin D derivatives and the corticosteroid. Now let's move in a bit of history, and history tell us that coal tar ointment has been used to relieve itching and irritating redness, dryness, scaling caused by psoriasis or eczema. It's that what we really know about this guys, the coal tar. They are work keratolytic. They have a keratolytic activity by slowing bacterial growth and loosening and softening of the scales. So they have a nice activity. And in the West, I think there's something called tar bath, and that's gonna take time. However, this type of treatment, which is the coal tar, is taking too long to have to produce an activity, and the availability of the vitamin D derivatives in combination with corticosteroid have limited the usage of such drugs. So historically it's been used, if you like, but now we don't really have much of usage of such disease, Similarly, dithranol, it's a substitute one for corticosteroid. It's have this activity, may restore normal epidermal proliferation and keratinization, useful in thick plaque psoriasis, commonly used in psoriasis arthritis. Two treatment approach, long contact and short contact. However, this drug, I said, also it's a historical drug that has been used. We don't really know the mechanism of action. However, it has an immunosuppressant activity, if you like. The problem of this drug, it's causing a bad color, like the tar, the one before. They really may stain the clothes. They return to the normal skin, and they may leave even pigmentation within the normal skin. However, this pigmentation can be removed at the end of the day, but the usage of these two drugs, the dithranol and the tar, has really reduced. But you really need to know that there's an application of such two drugs. Why we do this? Because they are inhibiting the proliferation and keratinization. So if you can say the mechanism of action of coal tar and dithranol, it's inhibition of proliferation and keratinization that's happening during the psoriasis. Okay, now back to our guys, which is the retinoids. And the retinoids also having, as we said in acne, if you can remember, in acne we said there's a immunosuppressant activity of retinoids. So in reality, retinoids having immunosuppressing activity. So why not to use them in psoriasis? Yes, one of them which is we used in acne, called tizarotene. However, we said this tizarotene have the highest irritation, if you remember, in acne. Now we will not really use the other guide. We will use the tizarotene as a cream or gel or foam as a topical agent. It's a retinoid prodrug which is converted to its active form within the body, within the skin, bind to all three. As we said, if you've been asked how the retinoic acid produce their activity, they're gonna bind to the retinoic receptors family, RAR, which is the retinoic acid receptor, or the retinoid X receptor. All of them are nuclear receptors, and they produce changes in gene expression. That changes in gene expression manifested by anti-inflammatory activity and anti-proliferation activity. Okay, so remember this. This is they resemble an activity of immunosuppressant, if you like, generally speaking. So tizarotene is one of the retinoids that we use. However, remember always teratogenic and teratogenic and teratogenic. And this drug is the most burning of them, I think, within the retinoids. Stinging, peeling, erythema, localized edema of the skin. So the drug is not to be used usually, except the other drugs is not really giving a good activity. However, because it's a potent retinoids, it's becoming more and more in use. But remember, if you apply it into 20% or more of the on the total body of the patient, it's gonna be, you will have a systemic activity, teratogenic activity within pregnant ladies. And remember, all retinoic acid derivatives are teratogenic. Now, if we're not really succeeding in inhibiting the psoriasis while using those topical drugs that we talked about, we need to change the strategy. And changing this, all if we applying the topical guys and there's a resistance toward these topical guys, you may need to add another drug that really have an activity against the psoriasis. It's not a drug by itself, it's the UV light now you're gonna use. Now, patients with psoriasis notice an improvement when their skin after after exposure to sunshine. So if the psoriasis people go out on the street and they found this and there's a sun on the street, they notice that there's an improvement for their psoriasis. Now, there has been a lot of investigation regarding this type of treatment, and we end up saying that there's only two types of radiation, if you like, that are really beneficial in psoriasis. It's the UVA and UVB are helpful to people with psoriasis, simply speaking. So either UVA or UVB are the helpful guys there. Okay, so ultraviolet light reduce inflammation in the skin. That's why it can be effective for psoriasis and other inflammatory skin disease. This is the hypothesis. Nobody knows how it does this. However, simply speaking, because UVA and UVB really having an activity on the DNA, and that activity on the DNA gonna produce let's say immunosuppressing activity. So if you're affecting the DNA of the skin, you may affect the strong turnover of this keratinocyte and epidermal cells. So simply speaking, what's happening during UV treatment is, if you are applying this, there's a, let's say there's a destranding of the DNA, and this destranding of the DNA gonna drive the cell toward apoptosis. So that's how UV light really gonna produce the activity in psoriasis. Selectively, they will affect the strongly proliferating cells, and the whole idea in psoriasis, if you remember, there's a strong proliferation that we don't want it. As we said, instead of 30 days of turnover of the skin cells, we'll have 5 days turnover, which is we don't really want, and there is no sloughing off. So UV light will have an activity, however the activity will not be really very strong. So what we're gonna do, We want to potentiate this type of activity. Okay, how to potentiate this type of activity? We're gonna give something to maximize the activity of UV light, and whenever we do this, we call the agents that we use is solarins. And solarins, what they really do, they will increase the sensitivity, so solar radiation. So we're gonna give them first, then we will apply a UV light with a machine to our patient. So what are those solarins? It include solarin, is the name of the agent, or our friend methoxysaline, or trioxaline, if you like. Whatever they call them, you have to remember all of them are solarins. They are furocomarines. You either apply them topically or systemically. However, remember this, you're gonna photosensitize the skin, so you will may have side effects, and that side effects may be burning of the skin and itching of the skin and hyper sensitization for the skin. So either topically or orally we give the patient, then we'll apply our UV light. What's happening there? The solarin is a photosensitive, it's the photosensitizing agent, and that will increase the effect on the DNA. And as we said, we selectively killing, if you like, or driving the apoptosis of those cells that really going in a fast, unpredictable, fast proliferation that we talked about in psoriasis, and that's the BUVA. Okay, UV, either we applied UVA or BUVA, and B stand for solarins. Now we're still on this type of mild disease. Staying toward the aggressive type, the severe pustular, if you like, psoriasis, where the patient is really suffering from a very bad condition of psoriasis. Now we're gonna go to our acetylretin, and which is the retinoids again, and it's related to the isotretinoin. It's similar to what we use in acne. We're gonna use an oral drug with this pustular psoriasis, have a good effect, normalizes dysregulated keratinocytes, and has anti-inflammatory activity action, as we said before. Regarding the activity of the retinoids, they're gonna bind to the RAR or RXR, which is the retinoic acid receptor, or the retinoic X receptors, and they're gonna produce changes in gene expression, and so forth, so on. However, remember this, accumulate in the fat, prolong half-life, more than 3 months after chronic use. Remember this is a very interesting story. They need the patient, that if she's a lady, she needs not to get pregnant after 3 years of using such a drug. It's hepatotoxic as usual, teratogenic, and if you remember, we talked about lipid profile, and you have to test for lipid profile, you have to test for hepatic enzymes, and you have to test to understand that your patient she's not pregnant, I will not be pregnant within the next years of using such drugs, even because they are very teratogenic. Remember story, adverse effect to acetylretin are similar to other retinoids, more teratogenic than others, should not be used in pregnant ladies or those who might get pregnant while on therapy or drugs, or any time after at least 3 years of discontinuation of therapy, and also should not donate blood. Remember this, very important. Now, all of that is good enough. If the retinoid will not work, and or your patient is pregnant, or at least we're not saying pregnant, maybe she will become pregnant or something like that, you may need to use drugs like immunomodulators like cyclosporine, or methotrexate. We talked about methotrexate before, rheumatoid arthritis, immunosuppressant. So cyclosporine, like methotrexate, cyclosporine is a drug that we talk about in immunology next year. So we'll not really dig deep within this. Also, there's a drug called tacrolimus, and that tacrolimus is like cyclosporine and bimecrolimus. All of them has been approved to be used in psoriasis. However, there's a real question mark here, because there's a black box, if you like, there's a black box warning on the prescription formation of these drugs that taken from the Wikipedia. So you really need to understand, there's a black box here regarding using drugs topically. Even these are topical drugs. Tacrolimus was a topical drug that increased the incidence of lymphoma and skin cancer in children and adults. However, methotrexate will not do that. Methotrexate will not be taken topically like the tacrolimus and bimecrolimus. Even cyclosporine will be taken orally. Both of them are immunomodulators, and they will have a nice activity. In reality, I believe in methotrexate as a good choice and a good drug for treatment of psoriasis. As usual, we'll use 7.5. I've done rheumatoid arthritis weekly, and we may increase it until 22.5 during the treatment. How does it work? Dihydrofolate reductase. Remember this. This is an activity gonna be more selective toward the T cells in the low doses, and however it's gonna take a time to produce the activity. It's gonna take months until we get the good real activity within the methotrexate. So we may combine it with a topical agent. Now, what's new in this field? There's a drug called oral apremilast, which is this is a very new drug, has been approved for treatment of psoriasis, and it's really interesting because we're turning the mechanism of drugs now to another story, which is the phosphodiesterase 4 inhibitor, and this is an enzyme that has play a role in the production of the multiple cytokines. So if we inhibit this guy, which is the phosphodiesterase 4 inhibitor, phosphodiesterase 4 here, we will inhibit the production of multiple cytokines involved in pathogenicity of psoriasis. That's what the mechanism of action of this guy. This is a new agent, hasn't been arrived to Jordan yet. However, it's becoming it's there in the market, and we really need to know about this guy. However, we use it to moderate to severe plaque psoriasis. However, this guy has interesting two stories. Now because we're getting more toward the metabolism, because to metabolic effect. So the patient will have a nausea, will have this short-term risk of diarrhea, upper respiratory tract infection because we are affecting the cytokines here. Okay, may have headache, and interestingly, the patient may have a weight loss. So you need to periodic monitoring of weight is recommended for such patient. Now I gotta teach you a very interesting story. Whenever the drug produce this type of diarrhea, we called escalation of the dose. So if you know your drug causing a diarrhea, that the patient may tolerate it with the time, and that's happening with a very interesting drug that we use it on a daily basis called metformin. So everybody is using metformin for diabetes. All diabetic patients taking metformin, and metformin characterized by this matter, that producing a diarrhea early in the treatment. Then after 1 to 2 weeks of using the drug, the diarrhea will go. So what we do, we escalate the dose. So we give a low dose, then we giving a high dose. Especially with similarly with this apremilast drug, we do the same thing, and you read this slide by yourself. But what we do, we give 10 milligram, then we give 20, then we give 30 daily, then we give 40, then we give 50, Then we end up with giving day 6 we give the full dose of 30 milligram twice daily, which is 60 milligram daily. And that type of treatment we call it escalation of the dose. So we escalate the dose to reduce the incidence of side effect, and this is recommended for a new drug that we don't have it in Jordan yet, but this is an interesting drug that we really need to know about. Ibrimilast, it's coming to Jordan. It has a different mechanism of action, and it's one of the newest ever drug that we, and we will end up the story with the new biologics for psoriasis. I'm not saying you have to memorize all those guys, but you really need to understand that what we're targeting in psoriasis, we target this guy, interleukin 23, okay, and we target interleukin 17s. Forget the names because all of them are MAP. We have Sticonomab, Gisolcomab, Tildrocozumab. We have, this is nice, you remember Secakinumab, which is I memorized this, interleukin 17 here. The other guys I read already is interleukin 23. Brodulumab, Ixicozumab, and very nice words. All of them has been approved within 2017, 2016 for treatment of psoriasis. They are expensive. Giving an example, secakinumab will cost 5,000, will cost 5,000 of treatment. It's very costly, I mean, and that cost is really it's gonna be very costly, and you have to give it to the patient longly, not just you give 6 months a course that causing, let's say, costing 5,000. No, you're gonna give it longly and continuously for the patient. So you wait until you graduate and you see what's happening with those drugs. But what's really interesting, you're targeting the guys that we talked about in the beginning. It's the interleukin 23, and the interleukin 17 here, and that's the guys that really having an activity within the psoriasis. So you're not targeting interleukin 1 nor 6 nor 8 nor 10. Instead, you're targeting this guy, interleukin 23 and interleukin 17s. All of them monoclonal antibodies. All of them gonna produce side effects like reduction of immunity, may produce more infection to the patient, giving the patient. You will read many recommendations within these drugs. If the patient developing a fever, you have to stop the drug for 1 month, then you continue giving the drug, and so forth, so on. Remember the allergic reaction toward, because part of the monoclonal antibody is murine based, if you like, or rabbit based, or it's not a humanized. They are humanized monoclonal antibodies, but part of them is not from human. So remember all of that. This is what we call biologics, and we will use them for those patients who are not responding toward all other treatments, because the cost will play a major